Good evening, ladies and gentlemen, and welcome to this very short webinar. What I'd like to share with you is a short little case which will show you and give you a little bit of an idea on how to do a socket shield in the aesthetic zone, as well as how to do, or how I do, the immediate provisionalization. So what I'd like to do is just take you through this case and show you a very short video on the technique, and then just discuss some of the nuances on how to do a successful socket shield. If we look at this case is a lady in her late 50s, and she presented with a request of wanting to replace the front three crowns. If you can see, there was a huge discrepancy between the gingival margins, and what we wanted to do in this area, we wanted to really look at getting the gingival levels right. Unfortunately, the first thing we wanted to do was look at orthodontic extrusion of the 2-1 or the number 9 tooth. However, the patient refused point blank to have any orthodontic treatment done, and as a result of that, there was not much that we could do. The margin was also too thick for us to actually cut the tooth down, cut the margin down, and actually do coronal repositioning of the flaps. So we decided to just leave the teeth as is, and the patient then went forward to go to have her crowns done. Lucky thing for us is that this patient had a hell of a lot of Botox as well as fillers, and as a result of that did not really show too much of the gum. So the gum level was not really an issue for us. What happened during the preparation work is that the patient had the provisional crowns placed. She had the endo done, as you can see in the final radiograph. But what happened is obviously there was weakening of the core, and a couple of weeks later she fractured off the core and was left with a ferrulous root. Again, the option of extrusion, crown lengthening was given to the patient, and that was our treatment of choice, but the patient decided that there was no orthodontic extrusion being done, and under any circumstances, and she'd rather go for an implant, which she had successfully done in some of the posterior areas. So what I'd like to do now is just share with you the video, the short video that I've created about this technique, and I'll talk you through the video. For any of you who want to visit us, you can visit us on our webpage, www.implantacademy.co.za. Here we can see the pre-op x-rays with very poor endo. The endo, as I said, was redone first because the whole purpose was to save the teeth, the fractured core. And this is how she presented to me now for a socket shield. The first thing that we did was create an index using lab putty, and this just helps us reposition the tooth in exactly the same position because we're going to use her own tooth as a provisional. The first thing I do is take a small round burr and I drill right through the tooth so that I can take the tooth off absolutely without grabbing it with a forceps and cracking or fracturing any of the porcelain. This was a composite core on a composite provisional, so the composite provisional shell came out, and that was absolutely perfect for us because we can now use that small shell to create the temporary. What we then do, you can see the massive composite core that's left, which has got no long-term prognosis. So we essentially just remove the whole thing now, and from the removal we are then going to start the preparation of the socket shield. So we just remove as much as we can, and once we've done that, we can start the preparation of the core. We use comet drills, and for those of you who want to see this technique in more detail, you can go to Dental XP and look online. There is a lecture that I've given on the socket shield technique, and it goes right through, and it also gives you the drills that you can use, and Dental XP also has a list of the drills, and they come from Comet. This is just a root resection drill, and I find it works far better than anything else. Once we've created the shield, we take out the palatal portion, and this really doesn't take me more than 10 minutes anymore, and it's a very simple procedure. Once we've taken out the palatal part, we then start to prepare the shield. We're using, again, comet drills with a long shank, and these are green drills, about 0.18 mils in thickness, and we basically cut the whole thing down to about 1 mil above the bone. The next step would be the creation of the osteotomy for the implant, And we place the implant obviously in the most ideal three-dimensional position, and it has no relationship to the shield at all. We just try and create a little bit of space between the shield and the implant. The implant is placed as far palatally as possible, and it is also placed around 2 to 3 millimeters below the shield at least, making sure that we've got it in the absolutely perfect position. There you can see the position of the osteotomy. We now place a 4.5 by 30 millimeter Megagen AnyRidge implant, which gives us really fantastic primary stability. And you can see even up to 50 newtons of turn-in torque that is set on this handpiece. We still have to go even higher, which is great, which means that this is really going to be an ideal site for us to be able to do a immediate provisionalization. So here you can see where we've got a little bit of space, 2 to 3 millimeters of space between the implant. Testing the ISQ with the Ostel gives us a level of 77. Testing with our stent to make sure that we've actually got it in the right position, and it'll give us ideal screw retained provisional, which is the way I like to do it. We put the cover screw in just to allow us to pack the bone, and so that the bone doesn't go into the well. We usually add APRF to that to give us a little bit of biostimulation of the bone that we place in, and we basically fill the jump gap. This is obviously not what was prescribed by Hertzler and Zur when they did this technique, but it is certainly something that I do as a routine, packing the jump gap, unless of course there is absolutely no gap whatsoever. What I do we're now going to place the titanium abutment, and the titanium abutment gets placed in position, and we now mark off the titanium abutment. Once we've taken an X-ray and we've confirmed that the titanium abutment is seated, we place a black marker, and that just tells us where next time that when we get it down that it's seated nicely and we don't have to take another X-ray. So we fit it now to the lab analog, and we use a carborundum burr just to remove the excess. And I generally don't allow this. A lot of people like to have this very, very long. I don't. I cut it as short as necessary, and I use the composite to actually hold the whole thing together rather than having the metal come right through the provisional. So now we've got everything in place. We put everything back into the index, and we just take a round burr with a straight handpiece and just create the hole in more or less the place where the screw hole is going to come out. The next thing we do is just create some space for the blue light where we can use so we can cure the composite. So we just cut a little bit of space. We then prepare. If this is porcelain, we'd obviously etch it with porcelain etch. If not, this is just porcelain, just bond that we use because it is composite. And here we use just a small cotton wool, a small toothpick with a little bit of Vaseline so it doesn't stick. And then we flow composite around the abutment just to index the whole thing, and then we flow the composite into the whole top there as well. And make sure you don't flow the composite subgingivally because you don't want that to actually get caught under the gum, and make sure you check afterwards to see that there's no composite. So we position everything in place, and then we take the blue light and we cure the composite from the buckle. After a couple of 30-40 seconds of curing, we take everything out and we cure again from the top because we want to make sure that everything's cured properly. We take everything off, and again we cure again to make sure that everything that we've got, all the composite that we've put in there, is cured, and so that when we take everything out, comes out easily and without any problems. So now we can unscrew it because we've indexed it, and you can see everything. We just cure again to make sure that whatever's come out is cured. We put everything back together on our lab analog, wash it off, take all the blood away, and then what we do is we start to flow our composite into the area so that we can start to create the ideal soft tissue profile that we require. Now, the type of contour that we're looking for is an S-shaped contour so that we can make sure that we get as thick a soft tissue on the buckle. And what we use is this rubber wheel just to help us shape. And the rubber wheel for me works well. You might have something else. And we create that S shape. We use temp glaze as well. which just gives us an automatic high shine, which we do polish off a little bit later as well, just to make sure that we don't leave any of the resin, which can give us a little bit of intolerance. And there you can see we pack a little bit more bone before we push everything down, and this is almost to follow the dual zone therapy, which was prescribed by Maurice Salama and Dennis Tarnow. With the crown back in place, you can see perfect positioning of our crown and the implant and the screw retained. Placing some Teflon tape into the area, and then a little bit of composite to close up our screw hole. Obviously very important to check the bites, and here you can see with anterior and lateral excursions that there's no forces on the tooth at all, protecting it in all excursions, removing the excess composite, rubber wheel to make sure that everything's nice and smooth, and then to finish off just a Soflex disc, just high shine Soflex disc, just to make the inside as comfortable as possible for the patient, and to make sure that they don't feel any hole in the palatal side of the tooth. And there you can see that's basically the way the patient walks out, a little bit red and swollen, but within a week that'll be back to a normal color. There you can see the immediate post-op. And now we start to see the benefit of Socket Shield, where we check 8 months later. You can see the exquisite soft tissue integration and even the occlusal vui, which we'll look at a little bit more detail in a few minutes. And the perfect soft tissue emergence that's created by the Socket Shield. And really, I don't think you get better soft tissue integration 8 months post-op than you get with this type of technique. So what we're going to do now is we're going to move on straight to the next slide, and you can see here, just to look a little bit closer at the integration check, and you can actually see very, very clearly the beautiful soft tissue profile that's maintained in this case. And you can also see, if one has a look at the pink of the once we've taken the healing abutment, there's no Socket Shield showing. You've got perfect healing around, there's perfect health around the soft tissue inside, which shows that there's good integration of the Socket Shield. And you can see the beautiful S shape, which allows much more thickening of the soft tissue. And if we look at this as well, you can see the soft tissue, how beautiful the curve that we've created, and the curve that's maintained in the soft tissue when we look at the lateral side of the tooth. And when we see the final crowns and we see the final integration of these crowns, you can see how beautifully the integration has remained, and the fact that 1 year later that we have absolutely zero collapse of our tissue, and the integration, the pink-white aesthetic is absolutely perfect in this case. Obviously there's a little bit of loss of papillae in the case, but nothing too bad. And if we look at the final crowns, you can see again we've still got that long tooth which has stayed that way, and the patient hasn't really complained about it and is happy because of the low lip line. But more importantly, if we have a look at these great crowns, and if we have a closer look at the integration, you can really see a beautiful pink-white integration. And I think that's essentially what we're looking for in every single case. So for me, the Socket Shield has become almost a standard of care now, and the results that we're getting and the up to 3 year follow-ups that we have are really absolutely stunning, with no infections, no problem with the Socket Shield, and really absolutely great integration. And I just say thank you very much for listening. If you want to get hold of me, you can either email me on docg@mweb.co.za, or you can follow us on Twitter at Implant Academy. Or if you want to follow our Facebook page, please don't hesitate to join us on Implant and Aesthetic Academy, where we post a number of cases. And I say thank you very much for listening to this webinar. I hope you've enjoyed it. And if there are any questions, please don't hesitate to ask.